Since Dr. Kumaran couldn't join us, he have recorded his video. Let me play the video for you on case studies in emergency situation and how he managed in his hospital.
Unless you face one. So this particular talk here, I'm going to highlight a process which was really life-saving and changing my career. So this is a code blue situation. We as ophthalmologists never have faced a lot of code blue situations in our practice. So these things could be new to us. If a code blue situation is going to be new to us, just imagine the plight of our staff. Hence, I'm going to take you through a particular incident which happened in my center way back in 2017. We were into 6 months into our certification. Just to take you an overview, this was a patient which happened in the December 12, 2017. It was a 64-year-old lady who was posted for a second eye surgery after the first eye was uneventful. She was shifted into the operation theater after initial assessment. All her vitals were normal. And after she was changed into her OT gown, she wanted to go to the restroom. She came out, she went to the restroom, and to the surprise of all of us, she just fell down and became breathless in front of her attendant. Remember, all this happened when I was into my operation. I was doing the 4th case on the particular day. So I did not know what had happened. So she was immediately shifted to the theater and the code blue was activated. And I could hear the siren of the code blue going on in the background. So what really went wrong with the patient? We have operated on her for the first eye. Everything was normal. But what went wrong? We really didn't know what to do. So we did a retrospective analysis going back to see what really had happened with this patient previously. So this was a particular patient who presented to us around 4 or 5 days back. Sorry. Yeah. So this was a patient who presented to an OPD one day. She had actually come from a nearby town, which was located around, say, 100 kilometers from place. Her son was living separately. So we did take a normal history. She was a diabetic and a hypertensive. Everything was normal. We did all the preoperative investigations and we went ahead with the surgery. Surgery was uneventful and she was discharged immediately after 1 hour of observation. She presented to us after 5 days. Her visual improvement was quite good. So we went ahead and fixed the surgery for the other eye. Normally, we would not reassess in 5 days. So we went ahead with the investigation was done later. So we did not know what really went wrong with this patient. What really happened after the code blue was activated? She was shifted into the operation theater. Her auscultation showed reals and racket. Her BP was sky high and the oxygen saturation was dropping. She was started on an IV line, injection Lasix was given, nitroglycerin. And we have an MOU with the nearby multi-specialty hospital, especially for situations like this. The BLS the ambulance arrived and she was shifted out immediately. And actually all this was happening in my background because I was operating on a particular case and I was occupied and I cannot leave the case and come out. So the theater anesthetist wrote all the notes, and I went and saw the patient after half an hour in the ICU in the nearby hospital. She was actually doing well, and I talked with her, and then I just updated the attenders on what was happening, and I reassured her. But when I came back to my hospital and started my OPD, I got a call back from the ICU stating the patient's vital dropped, and she had actually lost the patient. So she had a large intraventricular aneurysm which had ruptured, and we couldn't save the patient. So what really happened in this case? See, just imagine I started my practice in 2005. Those days we used to do only around 40, 50 cases in a year. And I never used to have an anesthetist standby or another doctor standby during my surgeries. Just imagine if this had happened long back, then I could have really been it could have been a very bad situation. So I would say I was really lucky because I did not have any of these situations early days of my practice. So what really happened? So this was an obese patient. We just took her words for granted that she was a diabetic and a controlled hypertensive. We did do her investigations, but everything was normal. So we were a little bit carried away with all these investigations. So all the investigations are normal. The first eye surgery also went on well, which also gave us a sense of confidence to go for the other eye. And during the code blue situations, we had difficulty in deciding if this was status asthmaticus or an acute MI. We had difficulty in finding an intravenous line because most of the cataract surgery, we do not start the patient on an IV line. And this was the first situation where we had a code blue and there was panic all around. And I was occupied with another case, which I was not able to leave and get back to this particular code blue situation. And there was also difficulty in shifting an obese patient on a stretcher into the ICU and the ambulance. We did not have adequate staff to face this kind of situations then. And the other major thing was that the CCTV camera did not function. Though we have a CCTV camera in all the lobbies, it did not function in this particular situation because we found out that recording in any code blue situation is very vital. We were saved by the fact that the entire code blue situation happened in front of the attender, and he also knew what was really happening. So there was no deficiencies on our part. Then we had difficulty in following the patient because I had to finish the surgery and go back into the ICU, to a different hospital. So what are the points we learned from this code blue situation? That you need to have a very high degree of suspicion in all these patients. Never take their word by granted. Look into all the medications. Follow all the protocols which lay in place. Have an intravenous line for all your patients, however small or big they may be, because most of the high-risk cases do not have a problem. The so-called non-high-risk cases are the one which gives you an headache and which can go into an high-risk situation. And check all your emergency medications. We always check the ophthalmic medications and the instrument during surgery. But our staff nearly tend not to check all the non-ophthalmic situations like a Boyle's apparatus, the intubation tubes, the oxygen cylinders. All these things have to be checked before you start your theater. And have a staff separately assigned for this. The more important, follow a core team, form an emergency team with minimum 6 protocols, and do not forget to record everything that happens during the code blue. So finally, the take-home message is that have a separate team, record all these code blue situations. Please do have an anesthetist standby or at least another physician standby to record all these events so that you are able to do your surgeries with peace. So this is the take-home message I would like to tell all the young ophthalmologists. You might not face a high-risk situation or a code blue situation during your surgeries all the time, but one situation is more than enough to spoil the peace of your mind and a career, because you know how the media could pounce upon all these kinds of situations. So to have a peace of mind and more than that, to take care of your patient, you should have an SL standby and a code blue situations, a BLS training to all your staff. In fact, we have also changed our HR policy in such a way that whenever a person has a BLS training certificate, we give him more incentives in a salary. So there are other common scenarios which we commonly come across in a practice is the hyperglycemia. This is a 50-year-old gentleman who was waiting in the and the OPD falls unconscious, becomes agitated. And what do you do? Check her ABCs, vitals, blood sugars, and always check the blood sugar before. So hypoglycemia is a common situation which you come across in
Right. So, so thank you, Dr. Kumaran, for the